Good evening, everyone. As we begin, I'll request President Rachna Jaiswal to come forward and call the meeting to order. Please.
Meeting call to order. Good evening, ladies and gentlemen, distinguished dignitaries here, my fellow Rotarians, and the LVPEI family. On behalf of the Rotary Club of Hyderabad, it is a privilege for me to welcome you all for this 26th Dr. Rustam Ranji Awards ceremony. I welcome on behalf of Rotary Club of Hyderabad to the entire doctor fraternity, the LVPI staff, and standing here, I stand here. Rotary has always been committed to service, knowledge sharing, and advancing healthcare. And today is a fine example of that spirit. We are truly honored to host Dr. Meenakshi Bhat, an eminent expert in medical genetics, whose pioneer work has brought new insights into rare genetic disorders. Her lecture today, The Eye and Rare Genetic Disorders, touches upon the area that is not only medically complex, but also deeply human, affecting lives and families in profound ways. We are grateful to the LVPEI family for partnering with us in this endeavor, providing a platform where science, service, and compassion meet together. I am certain that today's session will inspire us, deepen our understanding, and guide us towards stronger collaborative efforts in addressing such rare yet significant health challenges, ma'am. Once again, I extend a warm welcome to everybody present here our, and the entire Rotarian family. Thank you for being with us, and let us look forward for the enlightening session. Thank you.
Good evening, each one of you. Today's thought of the day: if you have a dream, never let go of it. Chase it till the end. Very appropriate in today's world. Thank you.
Good evening, friends. I have been given the honor of telling the four-way test for the Rotarians. So, in this, we have a four-way test wherein we have four questions we need to ask for all of us. Of the things we think we say or do, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendship? Will it be beneficial to all concerned? This is what a Rotarian should ask. Thank you for
Good evening, ladies and gentlemen. So once again, it's a pleasure to come and stand before you to tell you what LV Prasad Institute is all about, which I'm going to try to curtail in about 5 minutes. Tough task, but that's what I have to do today. So essentially, when you look at LVPI, as of today, for the uninitiated, we are at, as of March 2025, 310 centers, with the Center of Excellence in Hyderabad, 5 tertiary centers, the most recent one being opened in Kadapa, the others in Bhubaneswar, Vishakhapatnam, Vijayawada, 4, and the Center of Excellence. And we have 22 secondary centers with a couple under construction and in progress. They'll be open up in the year or so. Besides that, we have several vision centers. So all this constitutes a pyramidal model that we have established for ensuring that nobody goes without, having eye treatment available to them. And hence, we have these centers located in remote rural areas, which cater to a population of about 5,000. And gradually, as you climb up the ladder, and you'll see that in this pyramid. So we have the Center of Excellence, the tertiary centers, the secondary centers. So these centers, as I was telling you about, essentially we have 22 secondary centers with 4 city centers. And then we have the vision centers, which are located in the remote rural areas. So the vision technicians are located in the vision centers would identify patients with sight-threatening problems whom they're not able to correct. Essentially, what they're able to do is give glasses. And anybody whose vision doesn't improve or who has a problem which they've been trained to identify, those are referred to the next level, which is the secondary center. The secondary center is manned by an ophthalmologist and has a staff of about 20 to 35 people with them. And they're able to do basic surgeries, mostly cataract surgeries and simple ocular procedures. And then at a level above that, we have the tertiary centers, which are located in the 4 cities that I told you about. And the apex of this pyramid is a center of excellence, which is in Hyderabad. So essentially, we have patients being referred through different levels in this pyramid, but it's not just a down-up model. It also is a top-down model where we have faculty who visit these secondary centers and help out with patients who cannot travel, who have complex problems but are still unable to travel. And so we have faculty who reach out to them there. And similarly, if we want patients to be followed up and avoid the journey all the way to the secondary centers, so we have our colleagues in the secondary centers who are able to take care of them. And then this is all linked digitally because we're able to do teleconsultations. For those patients who require special care, we have a teleconsultation option available. And so they're able to seek our help even though we're sitting here. And so that's how it's been working. So we have these 10 functional arms through which we've been functioning all these years, with patient core being at the patient care being at the core of all of this. We have a very good iBanking network. Rehabilitation is one of the services that we've been offering right from the earliest days of the institute, where those with incurable blindness are given other means to integrate into society. They're empowered in a way that they're able to get jobs and fend for themselves. And this is unique to our organization because there's no other organization, which offers this kind of service. We do a lot in terms of education, I'll come to that later, as well as capacity building, helping others to set up eye organizations on similar lines, with a very strong rural and community eye health program, which I've just shared with you. In addition, there's the research component, technology innovation, product development, and advocacy, policy, and planning. So the highlights for the last year have been very significant because when you look at what we've been able to achieve, 4 of our tertiary centers, including the Center of Excellence, have been in the ranked in the top 20 best eye hospitals in the country. And in addition, LV Prasad Eye Institute, thank you. LV Prasad Eye Institute, yeah, big hand. Everybody clap. This is very half-hearted. Yes, thanks. Okay. So, so the LVP was also recognized as one of the top 10 best NGOs for the year 2024, and this is the award that we received from the Global CSR and ESG Awards, which recognize the achievements that we have. In addition, the iBank network that I spoke to you about has managed to harvest, several thousand corneas over the years, and we have landed up doing over 50,000 transplants that we hit that sometime last year, which is unique because there's only one eye care organization in the world which has probably hit this number of 50,000 transplants by a single organization. So, good clap. Thank you. And so the other achievement that we've had was like I talked to you about the Institution for Rehabilitation, we got the Governor's Excellence Award for the work that we've done because of the integrated vision rehabilitation right from inception. So this was an award that was received, and you see Dr. Beulah Christie here receiving it from the Governor. So we also realized that while a lot of our patients are able to travel to the organization and they're able to seek care, that's at the vision centers, secondary centers, as well as the tertiary centers. However, for those who are unable to reach us, we have the service which we offer, which is known as LVPI at home, where we reach out to individuals in their home using instruments which have been indigenously developed by us. So they get a complete eye care examination as well as a teleconsultation, and that's beneficial to elderly individuals, those with who are bedridden and who are unable to come to us for whatever reason. So this has been a good program that's been running with the help of funding from Stan Chartered Bank. This has been the impact for 2024, and you can see that the numbers are pretty impressive, where we've reached out to almost 8 lakh individuals or between 40 to 60, over 6 lakh who are over 60, as well as young people. Almost 45 to 50% are females, which is something which is quite remarkable, with a significant amount of surgeries being offered, almost 40% of them absolutely free to those who cannot afford it. On the research front, once again, for the third consecutive year, the Chicago Institution's rankings has put LV Prasad Institute in the top 10 globally. We are the #1 in India. We've gone up a couple of spots there as well, and we are the 3rd in Asia, and we are currently the 6th globally, which is a remarkable achievement for an eye organization. In addition, 17 of our researchers have featured in the top 2% of the Stanford's rankings, the top 2% of the world scientists ranking looking for 2024. So education has been one of our strong points, our forte being the fact that we trained all cadres of individuals involved in eye health, right from the vision technicians in the vision centers to the ophthalmic nursing assistants to the ophthalmologists. We offer subspecialty training to the fellows. We have got PhD students along with us. We have a lot of researchers in the research arm of our organization, and other paramedical staff whom we train. So this has been a strong point of our organization right from the very beginning. Plus, we've been involved in technology and innovation, where we have several devices that we have developed indigenously, one of which is the electronic health record that we use for all our records, we are paper free, in addition to the teleophthalmology, which we use, that's also developed by us, and the home care app, which is also developed by us. We also have a screening tool that has been developed with the help of Infosys, which involves, it's known as a Sight Connect app, where you can screen vision in the periphery as well. And these are some of the devices that are in use, which have been devised by the institute itself. So none of this would have been possible without the 5 values that are integrated into the DNA of each and every individual who forms part of the organization, the team that we have. This is a very old photograph of Dr. Rao, and the support that we have across the globe. So we have several friends, partners, donors, philanthropists who have been, walking with us in this journey over the last 38 years or so, and who have been instrumental in, helping us reach where we have reached today. So thank you very much for your patient hearing, and we'll continue with the guest lecture.
Thanks, Rachna, President Rotary, for giving me the opportunity to speak about this great award. I would just sum up into 2 parts. Basically, I have been given some 4 to 5 pages, but to be very precise and crisp, I would first talk about Rotary Club of Hyderabad. So, Rotary International is a global service organization with 1.2 million members in over 34,000 clubs worldwide. Its primary goal is community service, famously exemplified by its leading role in near eradication of polio. The Rotary Club of Hyderabad, founded in 1949, is the oldest club in the region. It has a prestigious history, counting presidents, governors, and other eminent personalities as honorary members. The club has a long record of service projects, including building schools and houses, supporting homes for the aged and children, providing health camps, immunization drives, and disaster relief. Now I speak about this great award. Dr. Rustam D Ranji was distinguished eye surgeon and a founding member of the club. He was deeply committed to Rotary, even closing his clinic on meeting days. A secret bequest upon his death in 1973 and later his wife's, it was revealed that they had secretly bequeathed a significant legacy to the club. Their niece, Roshni Patel, and her husband, Minu Patel, faithfully executed the will, tracking down the club to deliver the funds without any prior contact. The award inception to honor Dr. Ranji's memory and generosity, the club used the bequest to create an annual award. The suggestion was made by a member and actively supported by Dr. G.N. Rao of L.V. Prasad Institute of Eye Institute. The award is given each year to an outstanding personality who has made a significant contribution to ophthalmology or related field of community service. The selection is managed by L.V. Prasad, which has chosen a list of highly accomplished national and international awardees. Thank you.
Good evening, everyone. It's a real pleasure and privilege to welcome someone whose work has truly shaped the field of clinical genetics in India, Dr. Meenakshi Bhat. Dr. Bhat is a clinician scientist with an exceptional background. She trained in pediatrics at KM Hospital in Mumbai and earned her MD and DNB before moving on to complete her MRCP in Ireland and specialist qualification in clinical genetics in the UK. Since 2006, Dr. Bhat and her team at the Center for Human Genetics, along with partner hospitals, have been providing some of the most comprehensive clinical genetic services in the country. From full family evaluations to prenatal clinics and genetic counseling, her work touches every stages of life and care. She currently leads busy prenatal services not only at the Center for Human Genetics but also across Bengaluru. One of her landmark contributions has been helping to establish the Rare Diseases Center of Excellence at Indira Gandhi Institute of Child Health, the first of its kind in India. She also played a key role in drafting Karnataka's rare disease policy, which serves on the Indian Medical Advisory Board for compassionate access to rare disease therapies. On the research front, Dr. Bhat has worked on a wide range of genetic conditions, from dysmorphic syndromes and congenital heart disease to Noonan syndrome, so 22q11 deletion, and metabolic disorders like Gaucher's disease. Her team has been at the forefront of translational medicine, even partnering with the industry to create a low cost FSSAI approved medical diets now used across India. And perhaps one of the most ambitious projects she has led is the creation of cloud-based database of 27,000 rare disease patients. This platform is already proving to be a game changer. We are incredibly fortunate to have her with us today. Please join me in welcoming Dr. Meenakshi Bhat.
Request Dr. Balu, Dr. Rao to come on the stage to give the award.
Good evening, everybody. I cannot tell you how incredibly privileged I feel to be standing here. I have always regarded this institute, which I visited first time in person about 10 years ago, as a role model institute. And I think the introduction of services that was highlighted by Dr. Mal makes me feel like we have got a very long journey to go when you look at how far the reach is of the institute. So it was, I was always interested in rare diseases. It got called rare diseases, but these were genetic disorders. And what happened was I trained in England because at that time there was no training for clinical genetics. Today we have several programs. And then when I came back, there was very little by way of laboratories offering diagnostic services. There were plenty of researchers and also really setting up in the beginning the things that happened. So I think it's serendipity that I'm standing here. It's just some of the work that we have done. But this would not have been possible if it wasn't for this gentleman. I'm here because of what he left behind and the kindness of the team here who has invited me. I'm especially privileged because Professor Balu is here and he's been on the governing board. He's been a chairman of our governing board. And because of people like him, we also aspire for excellence. And that's one of the things that we do in our institute. So our institute is not big, it's tiny. We have less than 100 people working there. So very few people that are there, but I think we work with, I would like to say, the same kind of dedication that the people at this institute work with. We also have the dual footprint of having medical doctors who work with patients directly, as well as having scientists in basic research. And then over time, we have developed public engagement because without that, you can't reach anywhere. We have not been as fortunate in drawing in the sort of large funds that have come by to make all dreams possible, although that's part of our dream. We are located very far from the real traditional institutes, Indian Institute of Science, NCBS. We are on the other end of town, and that was called the biotech cluster. And in there, to start off, trying to get patients and making them come through was like asking them to come to an ivory tower. So what we did was we started going to hospitals. And one of the partnerships that we have had right from the beginning is with the State Children's Hospital, the Indira Gandhi Institute of Child Health, which started as a 450-bedded hospital, but has grown into a 1,000-bedded hospital and is the referral center for Karnataka for all children for any subspecialty. I do clinics there, and so does my team, and we go out to other remote places like Tumkur, where we have been serving in the medical colleges there. Now, the reason why I came into the whole thing was because, as OMIM certifies and has been written in a review, 1/3 of all genetic disorders have got something major that's wrong with the eye. And it was only when we started collaborating with our pediatric ophthalmologist to start off with, and then with various subspecialties of ophthalmology, that we realized what the extent of involvement and partnership is possible with each of these settings. So 90% of any human gene, and that is 20,000 genes or so, are at some stage of life expressed in the eye. And because it's integrally related to the brain, we are always thinking about the dual implications of the eye and the brain in relation to the whole system of the human being. Now, a bit about rare diseases. So this is a term which has become, like AI, very much in the discussion. So rare diseases are, we don't have a definition in India, although loosely ICMR has decided that if a person is affected by a condition and it is less than 1 in 5,000 incidents, then this would be noted as a rare disease. In different countries, this terminology varies. In the West, it is 1 in 2,000 prevalence. And by the measurement of even 1 in 5,000, a country of our size has approximately 70 million patients on the lower side of estimates. So technically, it's not rare, but collectively, these are huge numbers, almost the same numbers as the number of people affected with tuberculosis in this country. So individually, there are 7,000 plus diseases. 80% of them are caused by genes directly or they involve genes. And sadly, less than 5% of them have any sort of treatment. So when we started off with our work, the whole hope was to sit and think about how to diagnose, what should get referred, how should people come to you, because many clinicians didn't know what goes to a genetics clinic. Over a period of time, we found that it was trying to do the right sort of tests and seeing that the patients got accurate diagnosis. And the game changer was when next generation sequencing came through. In the beginning, when you had to sequence all the roughly about, we're looking at the entire genetic critical areas. If you did a whole exome, it used to cost an individual 70,000 rupees. This is an out-of-pocket expense. It is not covered by any insurance, inpatient or outpatient, and certainly unaffordable to the majority. And it doesn't stop at the individual. If you're going to cover multiple gene tests and you're related to the family members, it becomes that much more difficult for a family to access it. And only in desperate situations did they do that. Over a period of time, like mobile phone usage, the costs have come down. It today costs about 10,000 rupees to a patient. And I believe that it will take an act of parliament to change the rule of getting it into the insurance sector, to get that change so that it is covered not by the individual, but by the system that has this. So this is the inheritance that we had when we had to deal with rare diseases when we started off. What did we do from 2006 when I came back from my training in UK and a short stint as a consultant there? We started setting up clinics and reaching out to patients. So what we did was we started seeing patients. You said 27,000, we crossed 40,000. I think we have got one of the largest databases for one center. In the UK, and I believe in other countries too, metabolic medicine and primary genetic disorders are dealt with two different sets of clinicians. Here we do the two together. We don't have the luxury of having separate sciences or separate specialists. So without knowing too much about how to manage, I knew how we could diagnose, but not how to manage metabolic disorders. We started seeing a lot of metabolic disorders, acute conditions like organic acidemias, phenylketonurias, the likes of these kind of things which present within the first week of life. And then you get to see a lot of what we call the chronic disorders, which appear in an otherwise normal looking child beyond the first 3 to 6 months of life. And this group is called the lysosomal storage disorders. One particular disorder, which has been my area of interest, and thank you, Gaurav, for mentioning that, was Gaucher disease. While worldwide, it is the commonest treatable lysosomal storage disorder. Treatment was available elsewhere in the world. Just to put it in perspective, if you have to replace the missing enzyme in the child, which is done on a continuous basis, you pay roughly about 30 lakhs for a 10 kg child per year. And then, depending on the weight increase, this is how it escalates. So way beyond the reach of individuals. And everybody thought this was luxury medicine when we started off. However, we tried to do what we could do, and we are trying to go forward. So with our 40,000 patients, we realized that about 1,800 patients as of date had lysosomal storage disorders. And this is more than the number of patients. This is one center's numbers. And we have more than the whole of Europe with its 27 centers in this single center. And of course, the vast majority are patients with Gaucher disease, which is a lipid metabolism problem. Now, of that, in the beginning, we reached out to the compassionate access program of drug companies that produce these medicines. And that became the basis to show how improvement happens and to see that it becomes a model for the government to start paying for this. And we then had to look for more consistent payment for other patients, because it looked like the luck of the draw that some people had treatment and some people didn't. In contrast to a lot of things that our clinicians here do, it's not a one-time treatment. It is a lifelong treatment if you get onto any of these therapies. So to keep seeing your patients again, keep doing, we then had to go to court. It was a public interest litigation by diagnosed patients from our center that allowed us to, and it was a government that was willing to listen. So Karnataka state became the first state in the country to fund rare disease therapy. And that became a prelude to us going to court very much more often. And I'll talk a little bit about it. And the university, the health university, set aside 10 crores per year to encourage research so that we can have improved therapies, and we have taken full advantage of that. In addition to that, some gene therapies came by, and for example, SMA, we work closely with the neurologists. Each dose, as you would have seen from this thing, in the commercial setting costs about 16 crore one time. We have already had 31 patients treated with some improvement and being followed up regularly to see for this therapy. But these are not solutions. We need to make these accessible to more people. So this was the type of Gaucher disease we used to see. Under the age of 2, they used to come with this vastly increased abdominal size with liver, spleen and liver enlarged, among other things, so much so that they looked like little lemons on toothpicks. And they suffered from all sorts of vascular problems, including bleeding into the skin. In contrast to the Ashkenazi Jewish population who presents with the same disease with different mutations as an adult, these were really severe diseases. And if we did not do anything about it, they would die within the first 5 years of life. So this is when we went to court, and this was the court judgment, which allowed us to go there. But on the theme of eyes, the most important thing is that the type that we see in this country is the neurological subtype. And the diagnosis of the neurological subtype is made through the eye findings. And just to highlight from there, it may be a simple strabismus, lateral gaze palsy, initiation of horizontal saccades can be affected as an early stage, and then we start seeing subtypes. So the far end and the bottom row, you see on slit lamp examination, there is this punctate calcification of the cornea, which is very, very distinct to a subtype that affects only the heart and not the liver and spleen. And we do not know why it happens and why this subtype has this sort of this thing. So I was very encouraged that you have a lot of histopathology that's looking at the eyes. And at the back of the eyes, both on the retina as well as in the vitreous, you see this white cotton wool deposits. These are possibly the stored lipids that are extensively found in older patients affected with neurological disease. These are the criteria for treating, because obviously enzyme replacement, it's a protein, it does not cross into some of these compartments, and you have to treat these patients far earlier in age before these complications come on. So the treatment itself is at two levels. The standard of care is what's circled down there, enzyme replacement. The body is not manufacturing or not producing quality enzyme because of a mutation, and therefore you need to supplement it. It's usually given as an IV infusion in a hospital setting once in 15 days and has to be given lifelong based on the weight of the patient. As they grow into adulthood, there's a new medication which is oral and can be used for stabilized patients, and this is called chaperone therapy, and it's fortunately oral, so they don't need to come into hospitals. Sometimes you can use it as a first line, but it all depends on age and age match. Now, when we treated, this was the court order from the state, and the state from 2016 started paying us for the limited number of patients that went to court. So we started getting a regular supply of money, and I thought that this was the end of our problems. We could focus on medicine and go forwards. And we created this center of excellence for therapies, because each of these therapies are so expensive as a vial of injection. You can't give it in a general ward. You may have complications because they are proteins. So you need somebody to monitor it, and we set up a model system of daycare ward where all our patients till today get infused. It's a public-private partnership model, and it works very successfully, and it's filled 7 days a week and has got dedicated nurses. The father of this patient that I'm standing with was the first one who got the government therapy. His father had committed suicide waiting for his child to be treated, and he was an only child. So it gave me great pleasure to be able to offer him therapy. He now is in high school. So what happened is we started seeing the success. And I'm just showing you two of the individuals who have given permission to share their pictures with me. She is a master's in pharmacy and is part of a clinical trial program. She's got Gaucher, carries her enzyme with her wherever she wants. But more importantly, the young man on that side, he is under 18 cricket team of India, and he is currently in Patiala training, and he carries his enzymes with him. So I think we have to. So I think these are small numbers, but we have something to show why we do this, in spite of the huge cost that it involves and the journey that we are taking. So among other things, we have incubated in our center a small private lab of PhD biologists who are working on creating a BioBetter, which will be a cost breaker. So at the moment, Niti Aayog is in discussion with us to take it to trial with ICMR. And we're very proud of that. And once that comes through, I'm sure it will be available for the country to use. The other lysosomal storage disorders, and again, when I heard from Sir about the corneal transplant program and the corneas that you're harvesting, is mucopolysaccharidosis. So we've got huge numbers of mucopolysaccharidosis, and the types 4 and 6 have got normal intelligence. In the West, it's treated with enzyme replacement. The difference is that they get weekly enzyme replacement, and it's twice the cost of the Gaucher therapy. We don't even have access to some of the subtypes that are being treated outside because the companies are not registered here. So we try to give them supportive care rather than do anything major with them. And a small number are on enzyme replacement therapy, and they definitely show improvement. And this is one young girl. She was the first one that I started treating. She's now a 27-year-old, and she helps with the support group for rare diseases in Bangalore. And she's a functional adult. She's a little bit on the shorter side, but very, very proud of how she looks and does. So I think it's the small successes that we are looking forward to be the basis of other people being taken on. So that's enzyme replacement therapy every week for 16 years without a break. So it's not easy when schooling, college, and other things, there's some practical issues associated with it. The latest thing on the block when we look at cherry red spots in the eyes, is that a whole host of lipid metabolism disorders come through. But what's come through in very recently in 2022 is sphingomyelinase enzyme. And this is for the Niemann-Pick type B. So there are certain subtypes of Niemann-Pick which don't have any intellectual problem. And so if you treat them, there's no compromise on the way they grow up as adults. So it was FDA approved a few months before our first patient got onto therapy. We have got 4 of the 16 patients being treated in our center. And we've got treatment started before US of patients with this, so that we are feeding into the data of how they go on to do. And based on because what was used in clinical trials in the US was some part of the data, and our patients obviously behave differently and have different mutations. So we were able to do this. So he's an artist, and he has decorated some of the walls in our institute, which we're very proud of. So what came along after some time in 2021, right in the middle of the COVID crisis, was the National Policy for Rare Diseases in 2021. We had formulated a state policy. It went on to become a national policy, and they incorporated some parts of it, but not so much on the prevention mode. There was just a subtitle of prevention. What they did was the focus is on treatment. Treatment in 3 categories. The group 1 disorders are those that require a one-time treatment, which would be something like a transplant. And these transplants can be solid organs, there can be bone marrow transplants or others. The group 2 disorders are these continuous therapies like Wilson's disease, like phenylketonuria, like metabolic diets, which cost anything between 2 to 3 lakhs a year, but can be supported. And the last group are these high-cost enzyme replacement gene therapies, which are really not within the purview of being handled completely by the government-related funds. And for all 3 categories, they were able to enroll patients from centers of excellence, and we were one of the first 8 centers of excellence recognized by the Ministry of Health and Family Welfare to conduct and enroll patients from there. A maximum amount of 50 lakhs would be given per patient. This works brilliantly for immune disorders, for growth hormone therapy, for transplants, but it doesn't work for enzyme replacement. And promptly, as soon as this happened, the state refused to give us any more money, and the center was not ready to pay yet. So there was a 1.5-year gap, and the patients who were going to school and going to college, and they just went off the list, and we didn't know what to do. Eventually, when they said health was a central topic, not a state topic, the state government referred us to the center, and the Supreme Court had to get involved. And it was a ruling that instantaneously got us at least an intermediary amount of money. I never thought that I would come back to this country to be attending court meetings. We still have a couple of cases ongoing, all related to rare diseases, in the hope that we can get patients onto the due therapy that is required to them. So we did get 3 crores from the central this thing, and that's how we've been continuing. So among other things, we also focus on the very basic genetics. My colleague, Professor Jairam Kadandale, he heads the cytogenetics lab and advanced cytogenetics, and we offer this free of cost, all these between 3,000 and 5,000 tests a year, free of cost to patients who cannot afford it. So if you find something like a ring chromosome 13, I think knowing the location of where the RB1 gene is located, besides doing the molecular diagnosis. Incidentally, RB1 was the first gene ever found in molecular ophthalmology. We were able to track down, look at the eyes and find an early retinoblastoma. So early therapy obviously has good this thing. So I think we have a role in looking at things comprehensively if we can do things systematically. You have a Marfan-like phenotype. They have long fingers and toes. They're very thin, and they have dislocated lenses. We always think of an autosomal dominant single gene condition, but sometimes if you have intellectual disability, this could be homocystinuria, which is an acute metabolic disorder. And there are many genes, but the step of treatment is common, and that is giving them low protein diets, which were not available in this country. I do not know why. I came all the way here to the National Institute of Nutrition, CFTRI. We went from place to place to ask them to make, and we finally got a very small organic weaning food company to partner with us, and they started making the pristine foods. Today we have for 14 different disorders these diets, and in our center alone we've got over 350 patients on continuous therapy, and we subsidize it for them. We buy it at a certain cost. We started giving them free, but compliance goes down if everything is free. So we subsidize it and we give it to them, and that is supported by some of the private donors. So what is happening is we are getting a whole generation of children. Instead of having seizures and intellectual disorders, they're going to mainstream school, and their parents are learning to see that there is compliance and the right sort of follow-ups that we get from that. So this was very gratifying, and it's been going on for about 8 years, and it's the only products available in the country that are recognized yet. There are no other companies that make it. Wilson's disease, we know that there is penicillamine, we know that there is trientine, and trientine was terribly expensive, had to be refrigerated, imported from the UK, and we have started working with companies here through Niti Aayog to make it in India. Loris Lab, which has got a footprint here in Hyderabad, is producing some of our rare disease medication at a fraction of the price, and there are other things that have been prioritized. The second treatable condition, the two commonest tumors that we see with this very common disorder, 1 in 1,000 to 2,000 is neurofibromatosis, and the two commonest tumors involve the eye in some form, either plexiform or you have the gliomas, and both of these can be addressed to some extent if you have monoclonal antibodies that are selective to the eye lesions. And our first patient is going on treatment with this now because AstraZeneca has got a registered product in the country. So this can be covered through the rare disease policy, and being on the Central Technical Advisory Committee, it's possible for us to look at the disorders that can be included under the policy and eligible for treatment for this 50 lakhs. So we're trying not only to work with the companies to bring down their prices, but also to try and work with the government to encourage these disorders. Today there are 63 disorders included in the rare disease policy for treatment. And of course, Niti Aayog got involved in helping and supporting, because individual centers cannot force drug companies to make something that is not of great profit, small numbers. So these are some of the medicines, the oral medication for Gaucher disease and these other conditions that are already almost in the market. This year they will all be in the market, and they will be about 1/50th to 1/90th the cost that it otherwise costs as generics. So we're really happy about that. The controversial part is prenatal diagnosis. Now, if you have an ophthalmological condition and it only is restricted to the eye, and it happens again and again in a family, should you be offering them a test in pregnancy with the end point being stopping an affected pregnancy? And this is very debatable. I do not think that there are any absolute answers, but for a family who has 3, 4, 5 children being born with severe blindness without the support systems that are present in the West for specialized education and all the other accessories, so you have to sit and look at the possibility of offering testing. We have a very robust fetal medicine team. It used to be in the private sector. You'll be surprised to know that there are hardly any prenatal diagnostic centers in the whole of the country in government settings that offer high-end testing. So we have just opened last month in Indira Gandhi Institute a fetal medicine center, and already we are packed out completely. So we have patients coming through. And like in this state, we have the problem of consanguinity. So marrying within close relatives increases the burden of autosomal recessive disorders where parents are carriers from both sides. There are a host of disorders that we deal with. I'll just illustrate one example. This was a child who was the first child, the male child who was born and died at 2 months of age. He had sepsis, but this was the eye picture. His parents more or less gave up on treating him because he was completely blind. Except for this picture, they had nothing else. They threw away everything. He was not investigated. Based on that and the subsequent 2 pregnancies, so what we did was we saw them in the second pregnancy, and we needed to start somewhere. They came pregnant. So we worked up both the parents. We did carrier screening by all the 7,000 genes, 20,000 genes being checked in all of them. And we found that the parents were carriers of a very rare gene. And the genes marked out there, both of them had the PXDN gene in heterozygous form. So we counseled them and we offered them testing, and of course the child was affected. Now, this was the earliest 16 weeks. Nowhere in literature do we have of this thing. And then we were also slightly doubtful because although it's a pathogenic gene, our question mark was we've never tested an affected child. So how do we go forward? So then we got the scans done, and you will appreciate the size of the globe on one side is smaller. You can see the small yellow arrows, and they then decided to terminate the pregnancy. This is a 17-week fetus eye, and you can see it's similarly affected. So this became the basis in selected families to offer prenatal diagnosis supported. This is not something you can do loosely and offer randomly. We have to be very careful about what you say and how the tests reveal itself. So this was not the only one. We have recently presented our data from 1,000+ families in which we have had ocular prenatal referrals, and we have done prenatal diagnosis in about 130 of them. And we have got documented pre-post with counseling images from each of these and tissues from some of them. So this is how we have been looking at data, and I think there is a role for prenatal diagnosis in a country where recurrences are there, and in the rare disease policy, the government has offered to treat 1 child per family, not the second one that's born after diagnosis. Nothing happens without training. You people have a huge number of training programs, and we have beyond our MSc and PhD a whole host of clinical programs, short-term, long-term, or disease-specific, and very hands-on so that our people can go out. There are less than 200 clinical geneticists in this country trained, and we have produced 20 of them through our fellowship programs through. They are small numbers, but it all adds on to look at this very subspecialized area. And it all to say what needs to come to a, I think that the disease has to be perceived. People are very, I think, almost give up on the step 1 when you have recurrent miscarriages or you have children with neonatal deaths. They don't know that this is genetic. So to know what needs to be referred, for many years we have done a lot of working with the public and raising public awareness in any forum that allowed us to speak. And of course, through the media, trying to talk about diseases, when they should be referred, what should happen in all the types of, whether it's vernacular press or otherwise. And when the money started coming into the rare disease policy, today we have 300+ children on treatment, but we were the first center to have 100+. None of the aims or anything could enroll that quickly. I don't think it's because there are more patients in the south as versus the north. I think it's just reaching out to the right group of patients at the right time to get them onto therapy before the morbidity has settled in. So that's how we started. That's the ward where we treat them, with a daycare ward. And now Dr. Indumati is here. We have been given money by the state government and selected to set up the Center for Advanced Genome Editing and Gene Therapy to see that we can make newer therapies and cost-effective therapies through CRISPR-Cas. And one of the first diseases that the faculty who's joined is working on the cilia-related disorders, Bade bill that he picked up, and on advice of the advisory committee to look at ocular disorders with just the cilia and the eye being involved. So that's where we have started off. Our second faculty is about to join. And my dream is that while I'm still part of the team, we set up a research and training center where multiple therapies can be developed and easy diagnostic kits, which are very rapid and cost effective. At the moment, we're working on sensory neural hearing loss because 50% of all hearing loss is caused by genes that appear in the early childhood. And if we can get a bedside test just after birth, then we should be able to identify them and have effective cochlear implants put, because that is subsidized by the government. So this is what we are working towards. And it was an early paper in 2011 that wrote that the growth of molecular ophthalmology has increased the need for experienced clinicians who can place the observed genetic variants in the correct clinical context. I think that's what all of you are doing. I'm so proud to be here. Thank you.
That's a great speech. Thank you. Okay, a club announcement for Rotary Club. We have on 5th October, we have a family fellowship, and sincere thanks to each one of you for your presence on this great day. Have a wonderful week. Thank you.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे